Now, we got our presenter tonight is Dr. John Mulhall. He's residing right now on the DVD in my computer because he actually lives in New York. He's a board-certified urologist and microsurgeon. He specializes in sexual and reproductive medicine as part of Memorial Sloan Kettering Cancer Center's Survivorship Initiative. Between Dr. Mulhall and his team, they see more than 2,000 patients each year, and they specialize in the management of erectile dysfunction. He's the associate editor of the Journey of Sexual Medicine and currently the Secretary General of the Sexual Medicine Society of North America. He published a very popular book in 2008 called Saving Your Sex Life, a guide for men with prostate cancer. And this is aimed at informing men diagnosed with prostate cancer about the sexual effects of surgery, as well as educating them in ways to maximize their recovery. The book is available through Amazon. If you want to have a look at this after the meeting, please feel free and see if you want to order one. I think they're about $15 right now on Amazon, but it's an excellent book for a lot of reasons, and maybe you'd like to see it. So, that being said, we will go to Dr. Mulhall, I hope.
So, I look at this guy's bio and CV, John Mulhall, who's actually at Sloan Kettering, and I decided I'm not even going to actually look at it because I've known John for a very long time, I don't know, 15 years, and I'll just make it short and simple. First of all, I want to say, part of me feels sorry for him because he's probably heard more Viagra jokes than any doctor should be allowed to hear. So, for example, did you hear that Viagra has a new side effect? And that is, if you don't swallow the pill quickly, you get a stiff neck. Have you heard that one? He probably did. He said he heard that. But at the same time, without sounding too obsequious here and without embellishment, I know of no better person in the world on this topic. Actually, when they called me and said, we want you to moderate, then give a lecture later on, and we want to bring in someone on this topic, I said there is one person, and I'll tell you why. He produces more papers, does more good research, also has an outstanding book out that's in many of your bags that he's produced. So he just doesn't talk about it. He's constantly researching it. He's seeing patients. He travels the world. He was in St. John's, Newfoundland on Friday, and I was there on Thursday. So it's a miracle he's even here today. So I'm glad he made it. And without further ado, the king of erectile dysfunction in this topic, John Mulhall. Thanks.
It's my pleasure. Thank you, Mark. Mark and I have known each other for a long time. We're actually good friends, and I think that Mark and I share a number of things, one of which is passion, and I hope that that comes through during this talk. I'm an unusual urologist in that I really just have a practice that is 99% limited to sexual and reproductive dysfunction. And much of my 13 years in academic practice has been devoted to the research of why does radical prostatectomy, radiation therapy, and hormone therapy cause sexual problems? How do we prevent that? And how do we optimize management of those patients? So we see about 700 post-prostatectomy patients a year in my practice. We see about 150 radiation patients and about 100 patients plus who have the triple hit, who have surgery, radiation, and hormone therapy. So we have extensive clinical experience in this area. I always like to start out this talk with this statement from John Hewlings Jackson, who's a neurologist in the 19th century. It takes 50 years to get a wrong idea out of medicine and 100 years to get a right one into medicine. And the right one for this talk is to give you, the man with prostate cancer and his partner, if you have one, realistic expectations. And I could stop the talk right now because the bottom line is that you are practically never given realistic expectations. Not by your GP, not by your urologist, not by your radiation oncologist when it comes to sexual function and the problems that treatment cause with sexual function. It is a crying shame. And until you out there stand up and demand better education up front and better care after your treatment, this will not change. Women with breast cancer have done this for 3 decades and are incredibly successful. at changing Congress, and at changing how physicians practice the care of the breast cancer patient. There is an onus on you. You have a responsibility for those people who come behind you with a diagnosis of prostate cancer. Responsibility to them to do a better job. Stand up and start shouting. So we're going to start off, this is a potpourri. The master set of slides has 220 slides in this talk, so it's whittled down to a 30-minute conversation. We are going to have a chance to go to a breakout session shortly after this for those of you who don't have questions answered here. Optimal sexual function outcomes after prostate cancer therapy requires fully informed consent prior to therapy, which mandates that the clinician gives you realistic expectations. There are barriers to that. There are clinician barriers, there are patient barriers, and there are healthcare environment barriers. There's limitations put on your ability to access certain therapies by your healthcare insurers. That in itself, in my opinion, is a crime. So what are the barriers to optimal outcomes? There is knowledge. Your knowledge, physician knowledge. You must go in to a decision-making process fully understanding what the consequences are of all treatments on your future sexual function. If you're a sexual being, you must understand that, and at this point in time, most people don't. Technical expertise, there is surgical technical expertise, and that also applies to radiation oncologists. Substandard technology, for example, there are very novel ways of delivering radiation therapy that may have less impact upon your long-term erectile function. There are certain medical institutions that don't have access to that. Insufficient support. The care of the prostate cancer patient who has sexual problems after treatment cannot be taken care of solely by a single physician. We need support group, we need mental health professionals, we need nursing staff in the office. It is labor intensive, it is costly, space intensive, and that is one of the reasons that physicians don't want to touch it. It doesn't reimburse well, it's not going to make them rich. But the number one reason for regret in prostate cancer patients is sexual dysfunction. There is bias. We as physicians project onto our patients. 65-year-old physician who hasn't had sex with his wife in 10 years, what are the chances that he's going to project onto you and say, listen, the guy's 62, sex can't be that important to him. We must not, as physicians, project onto our patients. We must define from our patients what their level of interest is in sexual function before treatment and give them realistic expectations. This is from the Pfizer-sponsored global study of sexual attitudes and behaviors. Patients, men and women, were asked after coming out of their physician's office, has your doctor asked you about your sexual health in the last 12 months? On the far right-hand side, you'll see North America. USA and Canada. 14% of patients walking out of the doctor's office had ever been asked about their sexual function in the prior 12 months. This is not the prostate cancer population, but still, physicians are uncomfortable talking about sex. 2/3 of patients who do not bring up sex to their physician do not bring it up because the physician, they believe, will be embarrassed when they talk to them. How can a physician be comfortable? We get on average 2 hours of sexual health education during medical school. We give a vibe to our patients that we don't really want to talk about this. Unless you are proactive, unless you go in saying this is something very important to me and I want to talk about it, I want to know the real deal, the physician is not likely to bring this up. You think that physicians will tell you everything you need to hear. They will only do that generally when you ask the right questions. And part of my job and the future of my career is going to be empowering you and giving you a toolkit to ask the right questions. That's how you get the best treatment. This is a table from my book. Every treatment for prostate cancer causes some degree of sexual dysfunction. Dr. Bond stood up here early on and said, focal cryotherapy, I published this, and the incidence of ED is such and such. There are many ways to define erectile dysfunction. And we've done a very poor job as surgeons and as radiation oncologists in really answering the true answer. What is the real incidence of erectile dysfunction after treatment? You can see that the sexual dysfunctions vary from treatment to treatment. Erectile dysfunction occurs after radical prostatectomy, radiation, and hormone therapy. And you can see on the bottom right-hand side some of the other factors that occur with hormone therapy, which are not necessarily sexual, but which I see all the time because of all the patients that I have in my practice who are on hormone therapy. So, the bottom line with optimal outcomes is that there are numerous ways in which patients fail to receive good information and realistic expectations. Clinicians often avoid discussing sex because of discomfort with the topic. Clinicians often practice ageism. Just because you happen to be 65 years of age, we should not presume that you're not interested in sex. In fact, the literature would suggest that 70% of 70-year-old men are having sex, 40% sex weekly. That may not be sexual intercourse, it may be sexual outer course, but they're still having sexual activity. And finally, you, the patient, must be proactive in getting the information that you want and need. We don't have a lot of time to talk about non-ED sexual dysfunctions, but there is a host of other sexual problems. Low libido, failure to ejaculate. 25% of patients in my practice, Memorial Sloan Kettering, after surgery, never realized they were never going to ejaculate again. Is that because the physician never told them or they didn't hear it? Not clear. But still, again, unrealistic expectations. There are other ejaculatory problems that are associated with treatments. Absence of orgasm, painful orgasm. 15% of men after radical prostatectomy, a little bit less after radiation, have dysorgasmia, pain at the time of orgasm. FYI, that's very alpha blocker sensitive. Flomax, Uroxetrol, those kind of drugs, very useful in men with orgasmic pain. Orgasm-associated urine leak. 20% of our patients have consistent urine leak within the first 12 months after radical prostatectomy. You may say, well, that's not a sexual dysfunction. It is a potent barrier to men resuming satisfactory sexual relations. If you leak an ounce of urine every time you have an orgasm, yes, it may be cosmetic and aesthetic, but is it a barrier to having satisfactory sexual relations? The answer to that is yes. Penile length alterations and penile curvature we're going to talk about very briefly here. So, if your physician says to you, well, listen, I took out your prostate was that long and therefore your penis is going to be that much shorter, that is complete rubbish. I have patients every day in my practice saying, well, my surgeon said, that's rubbish. We pull the bladder down to the urogenital diaphragm and the urethra. The urethra is fixed at the urogenital diaphragm, and you cannot shorten the penis that way. Early length changes are actually due to increased tone in the erectile tissue. That erectile tissue is a muscle. I don't know if any of you are Seinfeld fans. This is a very famous episode. George Costanza, in the pool, naked, woman walks in, shrinkage factor. When you're in the cold pool, cold shower, anxious, and early after radical prostatectomy, the penis is hypercontractile. We'll see men come in to see me very early on, 4 to 6 weeks after surgery. Very common. I say, what happened to my penis, doctor? It's being sucked back into my body. It is just hypercontractility of the penis, which is usually very responsive to regular use of PDE5 inhibitors, Viagra, Levitra, and Cialis. However, delayed changes, long-term loss of penile length, and I'll show you data to show you how common that is due to erection tissue damage, atrophy of your erection tissue. Think of your penis like your biceps. If you took your arm and you strapped it to your body for a year, of course your biceps is going to undergo atrophy. The same thing happens to erectile tissue. The problem with atrophy in the penis is that it's permanent. And we're going to talk about penile rehabilitation at the end, and the purpose of penile rehab is to prevent atrophy of your erection tissue so you don't have permanent erectile dysfunction. This is a table, very busy table. There are 5 papers in the literature, 4 of which show very clearly that there is a significant reduction in penile length in a large proportion of men. On average, that's about 1 centimeter. About 70% of men have penile shortening. This is a real entity. I suspect that for those of you who've had surgery out there, probably very few of you were ever told about this before your operation. It's becoming increasingly clear to me that there are patients after radiation, probably not within the first 1 to 2 years, but 3 to 5 years after the completion of radiation, who also have penile length loss. What about Peyronie's disease? Peyronie's disease is acquired penile curvature. Men who had a straight penis going into surgery, who after surgery have curving of their penis. A psychologically and physically crippling disorder. It is unclear why it is associated with radical prostatectomy, but it's clear to me that it is. And we will publish a paper in the very near future, which I think is going to cause a lot of commotion among urologists, which clearly shows that the incidence of Peyronie's disease after radical prostatectomy is far higher than in the general population. The belief is that radical prostatectomy and probably the nerve trauma at the time of radical prostatectomy in a genetically susceptible man triggers or accelerates the onset of the condition. So, bottom line with non-ED sexual dysfunctions, there are a variety of sexual dysfunctions associated with all therapies. It is important that you familiarize yourself with these problems, and it's unlikely that most clinicians will address all of these problems before and after treatment unless you bring them up. What about expectations? This is a busy slide here. This is data that we presented at the American Urological Association meeting this past year in May in Chicago. And we took men who came in 3 months after surgery. This is when I was at Cornell. I spent 6 years running between Cornell and Memorial, and now I'm just at Memorial Sloan Kettering. But we took men who came in within 3 months, 9 surgeons, several hundred patients, 300 plus patients, and we asked them what their perception was, their knowledge was of how they would function after surgery. We divided them to open and robotic. Time to recovery of functional erections. When did they think they would have recovery of erections? The open people said by 12 months they should be fine. The robotic patients said that by 6 months they should be fine. Clearly somebody is giving them wrong message. Why? 18 to 24 months after surgery before there's full recuperation of erectile function. And if you look down there, 30% of open and 40% of robotic patients did not know that they would not ejaculate. We are not giving our patients realistic expectations. So I may say this more than once during this talk. Let me make this very clear to you. This is what I do for a living. I publish 20 papers a year, most of which are on radical prostatectomy, radiation, prostate cancer-associated sexual dysfunction. There is not a single iota of data, not a single shred of evidence that robotic surgery has better functional outcomes, urinary function, erectile function, or cancer control than open surgery. Intuitive Surgical have done a masterful job at communicating that robot is better. Yes, less blood loss. Yes, you get out of hospital quicker. Yes, you probably get back to work quicker. There is no data that functional outcomes are better with one over the other at this point in time. That is not to say that will not be the case in 10 years' time, but now there is no data to support that. This is a paper we published in the British Journal of Urology very recently. We did a review of 75 robotic prostatectomy websites and 20 open prostatectomy websites, very high-profile websites, many of the names you would know. And we showed that not a single website had both accurate and comprehensive sexual function information on there. Most of the robotic prostatectomy websites had data that was directly cut and pasted from Intuitive Surgical's website. Not a word changed. So Intuitive Surgical have done a very good job, and our physicians have not given you, again, realistic expectations. This is a very complicated slide. I want you to pay attention to the last 3 rows. This is the impact of these factors on long-term erectile functional recovery. Age, patient age, not surgeon. The higher the number, the more impact it has. Surgeon volume, you can see, very impactful. But look at the last line. The surgeon, him or herself, directly impacts upon your recovery. Either the surgeon is a good surgeon or not. That's a very important message. Whether it's open, laparoscopic, or robotic. This is 1,300 prostatectomies, 10 surgeons at Memorial Sloan Kettering over a decade. The surgeon, him or herself, is critical. Choose your surgeon, not the approach. What about surgeon experience? Just look at the middle dark black line. On the x-axis is surgeon volume, lifetime experience, the number of prostatectomies performed by the surgeon. On the y-axis is the 5-year probability of having a PSA that's 0, undetectable. And you can see that that line doesn't plateau until a surgeon has had 250 prostatectomies done in his career. The estimate from Memorial is that you need to be doing 50 prostatectomies a year to maintain your superior surgical skills. Another issue that I see all the time now is big name open prostatectomists changing to the robot because it's sexy. What they don't tell you is that their outcomes that they have from 10 years of open surgical experience will not be realized until they've done at least 100, if not 200 robotic prostatectomies. What if you happen to be patient number 26? You'll never hear that from them.
What about external beam versus seeds? Well, I'll tell you right now, just as with open versus robotic prostatectomy, there is no evidence to show that one form of radiation delivery is any better than another. Again, I suspect, although we do not have data, that choose a good radiation oncologist, because no matter what he or she does, good radiation oncologists do better than a bad radiation oncologist using another technique. So be careful in choosing your treating physician. I'm not a radiation oncologist, but this is always an impressive slide to me. This is the explosion in modalities for radiation delivery over the course of the last 6 decades or so. You can see it starts off in the 50s with cobalt, and look at it now. It is confusing to me, and therefore it must be incredibly confusing to you. Let's talk a little bit about how erections work. Very easy. Your penis is like a tire. There's a hose and there's a valve. There are 2 hoses. The artery in the center of that erection chamber, the erection chamber is called the corpus cavernosum. And this artery, if you just look at the central screen here, this artery here is the erection artery. It carries blood in. And these little Swiss cheese spaces, which are very closed and tight during the flaccid state, caused by adrenaline. That's how our penis stays flaccid as we're sitting during this lecture, at least most of us. Sorry, Mark. And then under nitric oxide control, this smooth muscle relaxes, those spaces open up, and blood flows in there. That's all erection is. We need nitric oxide to have that happen. And there are little veins that sit between the muscle and the outer lining called the tunica, and these veins get squashed. And that is the valve mechanism. If you understand what I've just said to you, you'll know much more than your GP, your family doctor, and you'll know a lot more than some urologists about the valve mechanism in the penis. It's a very simple concept. Why is this important? The number one reason people have permanent erection problems after surgery, after radiation, after hormone, is that they have a problem with this valve mechanism, and that's called venous leak. So how does erection problems occur after surgery, radiation, and hormone therapy? Nerve injury at the time of surgery. Radiation probably causes some nerve injury, but it's probably a minor contributor. There are arteries that travel very close to the prostate. They're called accessory pudendal arteries. And for many men, they are major sources of blood flow into the penis. And in some men, they are the only source of inflow. These are not the usual source of blood flow, but they're close to the prostate. They can be damaged by surgery, and they can be damaged by radiation. Erection tissue damage, that biceps concept, that atrophy I talked about earlier on. And this is the only comment I have on psychological aspects, and of course there's an entire talk on this, but there's tremendous confidence erosion that occurs in a man with erection problems, whether it's related to prostate cancer therapy or not. The women in the audience know this. Men are only as good as their last erection. If your last erection isn't good, you walk into the bedroom the next time second guessing yourself, and then the third and the fourth and the fifth time it gets worse and worse, and once worse. That's adrenaline mediated. Adrenaline is the world's most potent anti-erection chemical. The number one reason why people, men, say, listen, I'm fully rigid, doctor. I'm like rock hard, and I go to penetrate and I lose it. That's adrenaline. And when you've had ED for a year, post-prostate surgery, and your erections start coming back, you have to rebuild your confidence. And it can take a long time for that to happen. So while neurobiologically, erectile function recovery really has maximized by 2 years, from a confidence restoration standpoint, it can take another 2 years for the men to get back their confidence. What does nerve sparing really mean? I get a lot of people who come in to see me and say, listen, my doctor said my nerves were great. They look fantastic. Why do I have erection problems? Erection nerve sparing means that the surgeon, using his or her experience and expertise, looked at the nerves and said, you know what, they look pretty good. It says absolutely nothing about the function of those nerves. Even going to someone like Peter Scardino, one of the world's best prostatectomists at Memorial Sloan Kettering, perfect nerve sparing, those nerves go to sleep. They go into a coma. And they go into a coma for approximately 12 months, and it takes them another 6 to 12 months to wake up fully. So nerve sparing doesn't mean that you're not going to have erection problems. And by the way, let me tell you, when your surgeon comes out after surgery and says, listen, everything went great, couldn't have gone better, that doesn't mean your nerves were saved. It's incumbent upon you or your wife or partner to say, well, how did the nerves look at the end of the operation? And this concept, if you read medical literature, bilateral nerve sparing, unilateral, non-nerve sparing, is rubbish. It is not an all or none phenomenon. There are grading systems in place to grade nerve sparing, good, bad, fair, poor, whatever they are. It is not an all or none. You can have part of one nerve preserved and all of the other nerve, or vice versa. You have to bear that in mind when you're going into surgery. Complicated, just concentrate on the red bars. These are men with excellent erections going into surgery who, depending on when they came in after surgery, had an ultrasound of their penis to measure their blood flow. The red bar is corporal veno-occlusive dysfunction, venous leak. That concept I just talked to you about. Very important concept here. The later a man presented to us and had an ultrasound, the more likely he was to have leak. And at 12 months, that incidence was about 50%. 50% of men, no penile rehabilitation, at 12 months had permanent erectile tissue damage. What does that mean? They have very little chance of ever getting back a natural erection. They will struggle to respond to a pill, and they're almost certainly stuck on penile injections. Venous leak is a time-dependent problem. What does radiation cause erection problems? Those little red dots there are in the erection chamber. This is the prostate. The distance between the apex of the prostate and this erection chamber averages 1 to 2 centimeters. It is an anatomical variant in you. You are what you are. It just varies from patient to patient. When your radiation oncologist is treating you, at least with external beam, and I believe with seeds, he's going to treat the prostate. He or she will treat the prostate, but will also treat a margin around the prostate. Most patients get radiation delivered to their penis. Much of the interest among radiation oncologists in developing new radiation delivery modalities is to minimize exposure of non-prostate tissues to radiation and therefore try and minimize erection problems. So this is, we published this a few years ago. This is a computer simulation model trying to assess how much radiation went to the penis. If you just look at the gray bar on the far right-hand side, that is the back 1 inch of the penis that sits right under the prostate, and you can see that more than 50% of the radiation, this was using 3D conformal therapy, it's just as true for IMRT, 50% of the radiation or so goes to the back portion of the penis. And this is one of the reasons that people can get erection problems after radiation. This is not working, guys. There we go. What about androgen deprivation therapy, hormone therapy? Well, I have to tell you, if you just pay attention and read any of my book, you'll get the sense from reading the book that I'm not a big fan of androgen deprivation therapy. I would say to you, of course, it is cancer curing. Of course, it is potentially life-saving. But your reflex question when a physician says to you, you need hormone therapy, is, doctor, what's the survival benefit? Because so negative are the consequences of hormone therapy, not just on your penis, but on other very important aspects, diabetes, coronary artery disease, etc. So devastating are those complications potentially that you really need to make an informed decision. And I think you need to ask the physicians, what's the survival benefit? If the survival benefit's 4 years, of course that's a no-brainer. If the survival benefit's 4 months, then you're going to have to start figuring out whether that's important to you or not. Testosterone is required for libido and erection tissue health. We need testosterone to keep that tissue healthy. When we have no testosterone, hormone therapy, that erection tissue within a very short period of time, within about 4 to 6 months, starts undergoing structural changes, permanent structural changes. Androgen deprivation therapy reduces the ability to have preservation of your erectile function after radiation. Also, your response to pills decreases with time. What about erection function recovery? This is a review of 24 papers in the 21st century post-prostatectomy. And if you just look at this here, this is bilateral nerve sparing, BNS, unilateral nerve sparing. You'll see a tremendous discrepancy in the incidence of ED. 90% in some series, 20% in other series. How could that possibly be? Is it that one center is just so much better at doing radical prostatectomy than another? And the answer to that question is no, that's not the answer. The answer is there's different ways to gather the data. We study different patient populations, and most importantly, there are different ways to say whether somebody has good erections or not. Different scoring systems, relying on physician assessment, etc. So a very complicated process. When physicians stand up at these conferences and say 97% of my patients are potent after radical prostatectomy, that is untrue. It is impossible to get those numbers. It defies the laws of physics and physiology that 97% of patients can be potent post-prostatectomy. What they're not telling you is that many of those patients are using pills and some of them are using injections to get back to be one of those 97%. I think realistically speaking, for the average man going into a surgeon having radical prostatectomy, you have probably, at best, a 50 to 60% chance of getting back to natural erections. With pills, that figure can go as high as 80%. With injection therapy, that figure in our practice is 92%. What are the predictors of recovery? The ones with asterisks beside it predict recovery after radiation. All of these predict recovery after surgery. Degree of nerve sparing, what your baseline erectile function was, how old you are, blood flow issues, as I've alluded to already, vascular conditions. If you've diabetes, hypertension, dyslipidemia, coronary artery disease going into treatment, surgery or radiation, your erectile function recovery is going to be less than those younger men who have less of those medical problems. There's a lot of interest at the moment in the concept that testosterone may in fact be a neuromodulator. That if you have low testosterone going into surgery, you may in fact impair your ability to have nerve recovery. And we've research in our lab and clinically going on at the moment to answer that question. Very important concept. This is data from Memorial Sloan Kettering. This is time on the x-axis out to 24 months. This is the number of men recovering erections with or without a pill. And you can see very clearly in the second year, between 18 and 24 months, many men continue to improve their erections. If a physician says to you, you should be fine for 6 months, that is an untrue statement. Yes, there are men who are fine by 6 months. They've had perfect nerve sparing and they're 45 years of age. For the average man, erectile function recovery maximizes in the second year. If you're told 6 months and it's not back to normal at 6 months and it's 9 months, some of you will experience a sense of hopelessness and will drop out of all treatment because of the sense of hopelessness. So we're giving our patients unrealistic expectations and potentially hurting them in the long run. Approximately 50% of men after prostatectomy have recovery of erections good enough for intercourse without medications. The number of men at Memorial Sloan Kettering in our database who get back to the same level of rigidity after surgery that they had before surgery is 15 to 20%. So when a surgeon says to you or a radiation oncologist says to you, you should be fine by X number of months or years, they're not necessarily saying that you'll be back to where you were. They're saying that you'll be able to have intercourse. 15 to 20% of our patients at Memorial are back to where they were before surgery. Erectile function rates of over 90% are unrealistic. For the radiation patients, erectile dysfunction rates are very difficult to define because radiation is a heterogeneous group of treatments now. It's seeds with hormones, seeds with boost, HDR, external beam with hormones. It's totally heterogeneous. It's very difficult to answer from the currently available literature what the incidence of ED is after radiation. It appears, when patients come to see me before treatment, I'm trying to figure out surgery or radiation, doctor, what should I do? It appears that 3 years after treatment, ED rates are approximately the same between surgery and radiation based on currently available literature. So what about penile rehabilitation? Penile rehabilitation is the concept that we give drugs to men or devices to men to protect their erection tissue from that damage I talked about, to get them back to where they were before surgery. Not just to make them functional, but to get them back to where they were before surgery. And it revolves around the concept of cavernosal oxygenation, the concept that your penis is a big vein in the flaccid state, the soft state, and it's a big artery in the erect state. And in the flaccid state, there's very low levels of oxygen. And what that does actually is it causes production of scar-producing chemicals. And those scar-producing chemicals are turned off by prostaglandin, and prostaglandin is produced by oxygen going into the penis. So in a healthy man, and we get 3 erections, at least 3 erections every night of our lives, before surgery, before radiation, before hormone therapy, the purpose of those erections, we believe, is to protect erection tissue. And when you have gone after surgery 6 months without good erections, everything is shifted in favor: low oxygen, collagen-producing chemicals, scarring of that erection tissue, venous leak. Rehabilitation is aimed at preventing that. Without going into any detail, there's now very, very robust evidence from 6 animal studies showing that Viagra levetirancialis, at least in a rat, is really protective of erection tissue after the erection nerves are damaged. Whether that model really represents the human or not is not clear. Can you advance the slide? It's not advancing. So, without going into detail here, there are a total of 6 papers in humans. 5 of them have a signal that using regular Viagra levotius Cialis or using injection therapy after prostatectomy is of benefit to your long-term erectile function. That erections protect, or everything that's good for your erection tissue occurs during an erection. Blood flow, oxygen, stretch of the penis. And there's a signal from 5 of these 6 papers that there's a benefit. I say a signal because there's no definitive large study that really answers the question. Now, there's been a lot of controversy about the study. It's called the reInvent study. It was sponsored by Bayer Pharmaceuticals. Levitra was the drug that was used. 423 patients, 87 centers throughout Canada, United States, and Europe. And what it showed was, apparently anyway, is that there was very little difference in outcomes whether you used Levitra regularly or periodically. The problem is, without going into details, the study was so methodologically flawed, in my opinion, and I've written about this, that it didn't really have the chance to answer the question. So, in my mind, I have discounted this study, and I've looked at the other studies, as limited as they are, but I'm seeing a signal in those studies that says that there's a benefit to use of PD-5 inhibitors, Viagra, Levotius, and Cialis, after surgery with some regularity, and there's definitely a benefit to getting erections. And the belief is that perhaps we're increasing oxygen in the penis, perhaps we're protecting the erection tissue. I will tell you that the lining of those Swiss cheese spaces in your penis is called endothelium. It also lines your aorta, your coronary arteries, your femoral blood vessels. It is the lining of all of our blood vessels. There is overwhelming evidence that PD-5 inhibitors are endothelial protectants. Viagra, Levotius, Cialis protect your endothelium. There is evidence to show from drug trials that the incidence of heart attack in men who are on Viagra, Levotius, and Cialis is lower than those patients who were treated with a placebo in drug trials. I believe that the future of PD-5 inhibitors is probably not in erectile dysfunction, it's actually in vascular health protection, and I believe it's only a matter of time before we have a study that shows that we can actually limit long-term cardiovascular events by use of regular PD-5 inhibitors, and I suspect that everyone in the room with time is going to be on an aspirin, potentially a statin, and potentially a new PD-5 inhibitor for protection of their vascular health. The principal arguments against rehabilitation is that the naysayers will stand up and say, well, there's no big, large study that shows that it's really of benefit. Translating the animal evidence to the human data is very difficult. The reInvent study, that Bayer study, very negative study. The biggest issue for patients, of course, is high cost. That cost is a huge barrier to people coming to rehab. At Memorial Sloan Kettering, if you do our rehab program, it'll cost you $2,500 if you've no insurance coverage. It'll cost the average person $2,500 over 2 years. If you're 50 years of age and you have 25 years of sex ahead of you, you're paying $100 per annum for the rest of your sex life. It's not a huge investment. The arguments in favor of rehab is that ED causes depression, reduced quality of life. Erection tissue damage is time dependent. I already showed you that. There are signals from the human studies. There is very good evidence from the animal studies that this is a benefit. And I just chaired the International Consultation for Sexual Medicine panel on penile rehabilitation, and very soon it will be published. And in that it will say that every patient should be given the option to pursue penile rehabilitation. What about Muse, the urethral suppository? Tremendous interest at Vivus, the company make Muse, about that Muse rehabilitation. Bottom line, no large studies to date. What is the big barrier to Muse rehab? Cost and penile pain. Muse is prostaglandin. For those of you who've had your prostate removed, who've gone on Caverject or Muse in the first 6 months after surgery, there's a very good chance that you experienced significant burning penile pain. The erection nerves are hypersensitive to prostaglandin in the early stages after surgery. What about vacuum devices? Well, if you were a vacuum device manufacturer, you would try to convince us that we should be applying a vacuum device to our penis every day of our lives. It's so good for our penis. The problem is that if you believe that rehab revolves around oxygenation, we know the vacuum device doesn't oxygenate the penis. There's no animal or human evidence to support it at this point in time. I can tell you that we will start in the first quarter of 2010 a study looking at vacuum devices as a rehabilitation strategy. Here's my concern. Because there's no evidence, if you're using vacuum device monotherapy as a single treatment for rehab, I believe that you're delaying the introduction of treatments that have at least some evidence behind them. We do have men who add in the vacuum device to regular rehab, and I have no problems with them doing that. Busy slide. Don't have time to go through all of this. We love to see patients before surgery. If they come to see us before surgery, they go on low-dose PD-5 inhibitor before surgery. If they don't come see us before surgery, they go on low-dose PD-5 inhibitor at the time of their catheter removal. We want to see them at 6 weeks. In that first 6 weeks, we tell the patient, we want you to try maximum dose pill on 4 occasions. And when you come see me, I want to know, when you took 100 of Viagra, 20 of Levitra, 20 of Cialis, what number on our 10-point hardness scale did you get? Where 10 is that. 6, you can just about penetrate. 0, completely soft. If you get penetration hardness erection, then you are a responder. That figure at 6 weeks after surgery at Memorial Sloan Kettering is 14% of our patients. 86% of our patients are not responders, and they go directly to penile injections. When we have a discussion about penile injections at 6 weeks after surgery, 90% of those patients do penile injections. Why? Because I pitch it as follows. It's to protect your erection tissue. Think of it like your biceps. We're putting you on injections at this stage to maximize the chances of you getting off injections. The longer we wait, the less likely you are to get off injections. In fact, we've just published a paper that shows that if you start rehab after 6 months, your outcome is more poor than if you started before 6 months. I think we can extrapolate from the radical prostatectomy population to our radiation patients and to our hormone therapy patients, and I think there is a role for rehab. We have a randomized controlled trial going on at Memorial with Michael Zalewski, one of our radiation oncologists, looking at placebo versus Viagra for 6 months after radiation. If you're not part of that trial at our institution, you come see me, I will say I think that you should be using regular low-dose PD-5 inhibitors, and I think you should be getting erections on a regular basis. And we have animal evidence from rats that are castrated that if you put them on regular PD-5 inhibitor, you don't prevent completely the erection tissue damage, but you limit it to an extent. And so all of our hormone therapy patients are on rehab also. This is the future of penile rehabilitation for surgery, for radiation, for hormone therapy, and it will be multimodal. We will be doing things, there are many drugs being explored now, to protect nerves and to help nerves regenerate. We will be doing that. We will be doing things to protect the endothelium. We know that PD-5 inhibitors do it. We also know that statins do it. We are a hair's breadth away from adding statins into our penile rehabilitation strategies, and we will be doing things to protect that smooth muscle in the penis, that biceps concept. Erections do that. We know all of these treatments do it, but coming down the road, not in the near future, but in the distant future, we are going to have gene therapy, we are going to have stem cell therapy, and a very exciting concept is that we may be able to take people who've already had erection tissue damage, and we may be able to reverse it by using stem cell therapy. That is being looked at in animals. I think we're probably a decade off from that in humans, but very exciting information. Bottom line, the best outcomes with treatment from a sexual function standpoint, best technology, best physician experience, best physician judgment. It's not just about in the operating room, in the radiation suite. It's about assessing the patient before and judging whether this treatment is good for them and taking care of the patient afterwards. Best institutional support systems, and most importantly, and finally, the most informed patient, and that's what you need to look for. Thank you very much.
This work? It's on? Thanks. All right, I got a couple minutes here. First, I want to thank the following sponsors for making sure Dr. Mulhall's book gets to everyone here. That's Abbott, American Medical Systems, Augusta Medical Systems, Fast Size, Uncura, and Slate Pharmaceuticals. So there's a copy, I believe, of your great book in all the bags. Wow. You should have been a preacher, too. First of all, I do want to say, just to get this over with, that knock, 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 that reminds me of me, by the way. I just wanted to tell you that.
That's not what you want to say.
Question one. So here's the deal. I talked to all the urologists, and all these people have surgery, and they don't know about taking Viagra, Cialis, and Levitra after surgery, after the catheter comes out. And so why doesn't everybody get this as standard practice after surgery, and how long should they be taking this?
Right. So 87% of members of the International Society of Sexual Medicine, 90% of urologists surveyed in the American Urological Association last year do some form of rehab. That is mostly pills. It is mostly started fairly early after surgery, within the first few months. I think that the earlier we start this, the better. I think that probably the peak amount of damage that occurs after surgery occurs within the first few months, and that's the critical time. We use it, classic example, 25 milligrams of Viagra every night for the first 12 months. If the patient is a non-pill responder, they go on injection therapy. We tell them we want them getting at least 2 erections a week. So the average patient in my practice is using 2 injections a week, and 5 nights a week he's taking low-dose Viagra. And those 2 injections a week don't have to be with intercourse. They don't have to achieve an orgasm. They want penile stretch, blood flow, and oxygen going into their penis. And we have plenty of men who are single, who are in a rehab program, and are very committed to it.
Will they keep their penis length if they use the pill?
Yeah, that's an excellent question. So we have an ongoing prospective study where we take patients before prostatectomy, we measure their penis length. It's one measuring person, so the same person's measuring everyone. 6 weeks after surgery, 6 months, and 12 months after surgery. And most of those patients are in rehab, and I can tell you at 6 weeks, the signal is, we haven't finished the study, we have 80-something patients enrolled so far. The signal is that at 6 weeks there's no penile length loss. So I have to tell you, if we can show that penile length loss is reduced by being on rehab, everyone's going to be doing rehab. Because men love their penis length. Okay? For the men in the audience, hands up here for whom penis length is not important. I thought so.
Okay, so there's length, and then I read in papers, and I know there can be a few laughs, there's also girth, or there's width. So what happens there? I heard that after surgery, it also, in terms of diameter, shrinks, not length.
Right. So really, length is really a surrogate for volume. What we really should say is penile size or penile volume, because the penis is a 3-dimensional structure, and when that erection tissue degenerates, it doesn't just degenerate in length, it degenerates in girth also. So it's very common that we see men who say their penile girth or the penile length has disimproved. There are other causes for that as well. Peyronie's disease, for example, is a scar on the tunica, the outer lining of the erection chamber, which contracts, so that causes penile shortening. And then some men put weight on. And the first place you put weight on as a middle-aged or older man is your pre-pubic fat pad. That's the area right in front of your pubic bone, and that overhangs your penis. And it makes your penis look shorter. So one of the ways you can increase your penis length is to get on a treadmill.
So we should warn the Marriott that tomorrow it's going to be very busy in the exercise room.
Well, I saw you down there this morning, so I know that
I was down there this morning. That's why I'm saying I make that noise. I was down there. LHRH. LHRH is perhaps the most popular form of treatment around the world, at least it's given. It's been, you realize this, it has its 23rd anniversary this year. That's how long it's been around for treatment. Every man on LHRH also on Viagra, also to maintain length, girth, and potency, yes or no?
The preamble to that is, listen, I'm pretty tough on LHRH agonists, and I want to put things in perspective for you. I'm not saying you shouldn't use them. Cancer curing, life saving, absolutely. Just get fully informed. I put all of my patients who are going to start on LHRH agonists, if we have some lead time, we'll start them on Viagra beforehand. We'll have them on during their Lupron therapy and until their testosterone level gets back into the normal range. Now you know that if you've been on Lupron for a year or 2 years, that the month after you stop Lupron or Zoladex or Trelstar, your testosterone level is not going to be normal. It's going to take a while. So we have many patients who are on LHRH agonist kind of rehab for 3 years because of that animal data that is soon to be published, actually.
You wrote a paper that I had to review that said that basically when you give a first prescription to Viagra patients, Cialis and Levitra, only half of those patients, or a little more than half, follow up with a second prescription. If these drugs are so great, then why aren't these men getting a second prescription?
Well, first of all, that study was done in the general ED population, and it wasn't done in the prostatectomy population. The prostatectomy and the radiation patients that I see are incredibly motivated, and so they're willing to pay out of pocket, and they're willing to do this, and it's a total rigmarole for these patients, and it's very burdensome, and it's time and energy sapping for them. The general ED population, just generally speaking, has false expectations. The guy walking into the doctor's office, I want to try this Viagra. It's usually, first of all, it's usually a doorknob consult. The physician is walking out the door, and the patient says, listen, by the way, okay? And so he gets a sample or a prescription with no education. So that's one reason. He gets a sample or a prescription with no appointment for a follow-up. And I say, if you were physicians, I'd say to you, if you're treating hypertension, diabetes, or dyslipidemia, how often will you never follow up a patient? The answer to that question is 0. But with ED, because of physician discomfort level, often patients don't get followed up. And that's the major reason that 1/3 of men drop out after one prescription and 50% of men drop out after 6 months in the general ED population.
I'll mention a few things. You tell me if this is reality or myth. My bike seat's causing problems with my erections.
If you're on that bike 100 miles a week, if you mountain bike, or if you suffer penile numbness, the answer to that question is possibly.
My underwear is too tight. Not mine personally, but I just want to know. Is that okay?
From an erection standpoint, that's okay.
Fertility standpoint?
You know, the kind of underwear that you have to wear to cause fertility problems is probably going to be so strangulating and uncomfortable that you're not going to wear it, okay? I think jacuzzis on a regular basis is not good for your fertility.
Okay.
Listen, it's very simple. The testicles hang outside of our body. Why? They need to be 2 to 4 degrees lower in temperature than the rest of our body. When they're not, then they don't produce sperm as well as they do when they're hanging outside the body. That's a simple reason. So when you're in a jacuzzi, you're basically artificially elevating the temperature. There'll be nobody in the jacuzzi tomorrow now. So.
Okay. Ejaculations, more or better, or less is more?
Better for what purpose?
So there's several studies suggesting that when you flush the prostate out or you have more ejaculations, that actually may reduce the risk of inflammatory issues and cancer coming back. But some people say, no, the more that you have actually can increase because testosterone might change. So what is the deal with ejaculations and cancer?
So I think there's mixed literature. It's completely unclear whether ejaculating regularly reduces your chance of getting prostate cancer. It's an intriguing concept. From a mental health standpoint, it's very bad for your mental health, unless you practice tantric sex or something. I think ejaculation is very good for our mental health. So I think that, I don't know that it's a benefit to prostate cancer, and I think that you should ejaculate as often as you wish to ejaculate.
Wow. I gotta make sure to call my wife after this talk.
I'll write you a prescription.
That sounds good to me. All right. A couple more questions, and we'll call it a day, and then you'll be around 20-25 minutes afterward to answer questions. A lot of women here. Can't be always just a guy. There's just as much interest in female sexual dysfunction. What's going on there? Can women use Viagra? We hear that women can use it. Can they use testosterone? And what's happening in female sexual dysfunction?
So FSD, female sexual dysfunction, that field is probably about 15 years behind the whole male sexual dysfunction arena. The reason for that is twofold. First of all, the gross taboo that surrounds discussing female sexual dysfunction. I did an interview with NBC Nightly News about 5 years ago, and the producer came on and says, now listen, you cannot use the word clitoris on TV. It's a G-rated show. You cannot use the word clitoris. So there is taboos that still exist that prevent us really doing good research, getting funding, etc. The second, and probably even a bigger issue, is there are not a lot of industry partners involved in FSD research. One of the reasons that ED is now so well talked about and known about is that Pfizer in 1996 started researching ED. And so there's a lot of dollars in research. That doesn't really exist in FSD. However, Procter & Gamble have a patch that I believe will likely get approved, a testosterone patch for women. Boehringer Ingelheim have a drug that will be used for female low libido. I think that's got a very good chance of getting approved. So we're starting to make some inroads into the whole female concept. Let me just, as an aside, before Mark asks the last question. It's really gratifying to me to see so many women in the audience, because I can do whatever I can for Bill's penis. But without you, he'll never get back to satisfactory sexual relations. You are the gatekeeper of sex in any relationship. Okay? And women ask me all the time, what can I do to help Bill now that he's 9 months after surgery and he's depressed? Please do not emasculate the man. It's very easy to do that in the first year after surgery or the first few years after radiation, and support him and be proactive. Men are often, they lack confidence, they lapse into a state called sexual neutrality. And sexual neutrality is where they don't want to initiate sex, they don't think about sex, but when they have it, they enjoy it. So be proactive and help your man get back on track.
All right, and so my final question is, still, everything that you talk about in the slides that you brought up, there are men who have this surgery and ED is such a strong complication, or after radiation, or after cryotherapy. In some men, do you use combinations of therapies, not just one? Say, using the pill with the Muse, or the injection with the Muse. I mean, are you using in some patients a series of treatments just in one patient, or is it just all about one treatment fits one patient?
Right. So first of all, everything is individualized, but I'm a big fan of monotherapy, because every therapy that we have you do is a barrier. It's different than what you used to do before your treatment. And so the more therapies we give you to do, multimodal therapy for sex, it's just an even bigger barrier. So taking a pill 2 hours before, and a shot, and then a vacuum device. If you don't respond to pills in my practice, I'm going to tell you that I think the best next step is penis injections. Sounds awful, easy to do. Painless, 90% of men get erections, good enough for intercourse. The average guy gets an erection in 5 minutes, it lasts 30 plus minutes. We're comfortable with up to a 90-minute erection. We don't usually add in Muse or vacuum devices with injections because most of our patients do superbly with injections. However, if you have leak and you're not doing well with injections, that's when we start going into multimodal therapy.
Okay, and favorite beer?
It depends on the day, doesn't it? Sierra Nevada.
Thank you. All right, thank you, everybody. I appreciate it.
Thank you.
Fred, you and Ken were actually in Los Angeles, and maybe you want to see if any of the people in the audience have any questions that we can maybe enlighten them on.
Let me say a couple of things, Bob. First of all, Ken and I, we said that we are a couple of the last people who should be making this presentation. In other words, we're well beyond this. However, I'll tell you an anecdote about myself. I went through prostatectomy and then radiation because it had escaped. And when I was on the radiation table, they concluded that my penis was up in the radiation beam area. And so what they did was they brought in a great big lead weight and ran a gauze bandage around it, and then tied a noose around my penis, and then threw that over the side and stretched it out of the road. However, that didn't help. It was I, Bob, who was at Los Angeles, and because of my lack of interest, I almost skipped this presentation because there are multi-activities during a conference. However, I stuck with it and listened. I was glad that I did. Mulhall is an extremely good speaker, and if you look at his book, it is very professionally written, and the diagrams in it are extremely good. Much better than I've seen in any other book. So I'm not sure whether they've got it down in the Prostate Cancer Center, which incidentally has now moved over from the Rocky View building on Glenmore Trail over to the Rocky View Hospital. It is located on the floors above the public parking structure. And if they don't have it, then I have a copy of this and I'm going to give it to them. So it would be available there within a few weeks. However, are there any questions? Wonderful. Okay, Bob.
All right, thanks for that. A final word from me. I've been standing up here most months for almost 10 years. I've been president of Prostate Cancer Canada network here in Calgary. Used to be known as Prostate Calgary, and before that it had many different names, but I've been with this organization all the way through. If you read David Parker's column on Friday, you probably know what he announced in that column, but I am stepping down as president of this organization, and at the May meeting, there will be a new set of directors elected, and from those directors, a new president will be appointed. So it's been a hell of a ride for me. I've enjoyed every minute of it. I resign with mixed feelings. This has been a baby of mine from day one, and it's really hard for me to step down, but I think it is time. As you probably know, I'm very involved with Prostate Cancer Canada. I'm the vice president of Prostate Cancer Canada and managing director now of the network division. And although I've should have been retired a long time ago, at age, I'm going to be 69 in a couple of weeks, I am back working full-time, and between that and my responsibilities with Prostate Cancer Canada and the network, it's just a little bit much. So it's time for me to step aside and let somebody else take over the reins of this organization. I will stay on as a director, and although I won't be at the May annual general meeting because I'm in Ottawa at a meeting, I will be here at the June meeting, but I'll be sitting down in the audience with everybody else. So I just want to say to those of you who are here, it's been great to be your president, and I know you'll give the incoming president all your support as we move forward. So, that being said, I think there's some coffee, which is...
I think it has to be said that during your tenure as president of this organization, you have set it at a level which most other sport groups can only dream of. You have brought in international speakers. You have been so influential in the business community and other areas around Calgary. I really think that we owe you a debt of gratitude. You have superseded all expectations, and you leave behind you a legacy that anybody would be proud of. Thank you, Bob.
Thank you. Somebody said I'm leaving big shoes to fill. Well, I wear a size 14 shoe, so that's true both figuratively and metaphorically. So anyway, let's have some coffee and conversation in the lobby.